Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday, and I think you know what's happening every Sunday. Today we are going to do our weekly newsletter number 17. I'm really happy we up to this number, and I hope we can go to like 100 maybe, I don't know. And the last few days we announced the full course, which will start in January, and we announced the details for that. I don't want to waste your time, but like you can watch the video on the Facebook group about it, and also for the mock package discount and everything. The questions we are going to mention today are important, and I'm going to make like a theme for each newsletter, not to be from one topic because it's dull to be from one topic, but I have in my mind clusters for topics, like meaning management, LA, and pharma is like one cluster, and B do operative prosthesis is one cluster, like surgery, ortho, because like orthognostic surgery and ortho anatomy is like one cluster, and otopathology is a cluster by itself. I cannot combine it with anything. So today you are going to mix it to be like 5 questions from, we can say, same cluster. So today it's like the management pharma cluster. So without being said, let's not waste your time and let's get started. First question from Pharma. Which of the following is a side effect associated with chloramphenicol? So chloramphenicol is antibiotic, which is aggressive antibiotic, wide spectrum. We use it when we have no other solution because it has a lot of side effect. So let's speak about the side effect. So staining of the teeth, auditory nerve damage, facial paralysis, or bone marrow suppression. So let's first discuss chloramphenicol as antibiotic. How does it work and the mode of action? So this chloramphenicol antibiotic belongs to the family which interfere with protein synthesis, as it's bind reversibly to the bacterial 50S ribosomal subunit and inhibit protein synthesis at the peptidyl transfer reaction. As you can see in the picture, chloramphenicol inhibit peptidyl transferase, which is this one. Due to some similarity of mammalian mitochondrial ribosomes to those of bacteria, protein and ATP synthesis in these organelles may be inhibited at high circulating chloramphenicol level, producing bone marrow toxicity. So there is some similarity between this like step in protein synthesis and the mitochondria in the mammals. So sometimes with some patient, it lead to bone marrow toxicity, which will lead to anemia and severe side effect for our patient. That's why we don't use these antibiotics unless we have no other resort. As you can see, the adverse effect anemia, as patient may experience dose-related anemia, hemolytic anemia seen in patient with glucose 6-phosphate dehydrogenase deficiency, and aplastic anemia. And aplastic anemia is dependent of the dose and may occur after a therapy has ceased. So you might give your patient the medication after few weeks or some few months, he has this side effect. Gray baby syndrome, neonates have a low capacity to glucuronate the antibiotic and they have underdeveloped renal function, as you can know. Therefore, neonates have a decreased ability to excrete the drug, and that's mean the drug will stay in their system, which accumulate to a level that interfere with the function of mitochondrial ribosomes, as we explained in the previous slide. This leads to poor feeding, depressed breathing, and cardiovascular collapse cyanosis, hence the term gray baby syndrome is coming from. And moreover, like it's really dangerous antibiotic. It has drug interaction. Chloramphenicol inhibits some of hepatic mixed function oxidase and thus block the metabolism of drugs such as warfarin and phenytoin, thereby elevating their concentration and potentiating their effects. So as you can see, chloramphenicol is a really bad choice for any condition, for any level. As for kids, it may lead to gray baby syndrome. As for adults, it may lead to anemia, and even for other medication like warfarin and phenytoin, it will lead to toxicity of those two medication. That's why we don't use it unless we have no other solution for our patient. And here I have a visual for you so you can correlate in your mind what's this, like severe side effect. So it healthy cells leading to aplastic anemia, and it lead to bone marrow suppression, and it lead to growth inhibition of metabolism. I don't know about this food chain, honestly. I don't know. Maybe just to complete the picture. But anyway, I would like you to correlate between a picture in your mind and the side effect so you can remember it. So this is Why? And I would like you to understand why specifically this antibiotics has this severe side effect. Okay? Okay, so let's read our answer here, our options. So staining of the teeth, I think you know this one, is tetracycline. Auditory nerve damage, this is streptomycin. Facial paralysis, no antibiotic relating to this one. And bone marrow suppression is a criminal here, is chloramphenicol. So for antibiotic side effect, you should know it. It's extremely important, especially the outliers. I'm not telling you when you see in textbook, it will give you a huge list of side effect. No, you should know it, but like when I'm telling you bone marrow suppression, aplastic anemia, you can catch it as chloramphenicol. When you speak about auditory nerve damage, it's streptomycin. When we speak about staining of the teeth or inhibition of calcification of bone, you know it's tetracycline. So at least you know the general idea, and then you have a coherent story in your mind which drug is leading to which severe side effect. Okay? Okay. Second question from pharma also. A patient present to the clinic for endodontic treatment. The patient mentions that he visited an emergency clinic a few days ago for his toothache and was given an antibiotic that resulted in a diarrhea. Which of the following drug was the patient most likely prescribed? So here it's like management and pharma question in the same way. So this patient did go to other dentists and he gave antibiotics, but he cannot remember the name. And he's telling you these antibiotics lead to diarrhea. So which one you think it might be the criminal here? Amoxicillin, clindamycin, metronidazole, streptomycin. So here our criminal is the clindamycin. So let's know why clindamycin doing this. Clindamycin has a mechanism of action that is same as erythromycin, as clindamycin is used primarily to treat in the treatment of infection caused by gram-positive organisms, including MRSA and Streptococcus. Okay, so this is the spectrum where we are going to use clindamycin for our patient. So let's speak about the formulation of clindamycin. Clindamycin is available in both IV and oral formulation, but the use of oral form is limited by gastrointestinal intolerance. Why? We're gonna discuss this later, but here he speak about the distribution of the drug. It distributes well into all body fluid, including bone, but except poor entry into cerebrospinal fluid, which is good because it doesn't go to blood-brain barrier, which is good for the clindamycin. But let's speak specifically about the side effect, and you can see it here now. In addition to skin rashes, the most common adverse effect is diarrhea, which may represent a serious pseudomembranous colitis caused by overgrowth of C. difficilis. Oral administration of either metronidazole or vancomycin is usually effective in treatment of C. difficilis. So the textbook is speaking about it's used and it's effective, it's amazing, but it has serious side effect. Apart from skin rash, it can cause diarrhea because it leads to overgrowth of C. difficilis inside your intestine. Because like antibiotics, when you go inside your body, it's killing some antibiotics and the bacteria inside your body and fungus as well, like they live together in harmony. When you kill one species aggressively, so you're leading to other species to like flourish and have nothing to compete for the food and energy available. So the other bacteria like flourish. And if your patient has this C. difficilis, you are going to give him metronidazole or vancomycin. And I have a question for you here, and I hope you can answer it. When you are going to give metronidazole and when you are going to give vancomycin, and this is an important question, I would like to hear your answer and what you think about it. So if our patient has this condition, pseudomembranous colitis, so when we are going to give him metronidazole and when we are going to give him vancomycin, okay? Okay, and let me give you here a visual about it. So it's used for oral infection. It can be combined with other medication. And then he speak about oral and IV mechanism is by 250S. Clindamycin work in this one is bacteriostatic and adverse effect nausea, vomiting, diarrhea, fever, rash, and Clostridium difficile enterocolitis, which is 6%. It's not very common, but it might happen for some patient. We use it for MRSA and soft tissue infection. We use it for oral infection. We're using it for lung abscess. So this is like visual to give you the whole picture about clindamycin, and this is important. When you study pharma, I don't want you to move from one antibiotic or one medication to other medication unless you have this. This is like a study card for this antibiotics for any drug. So for any drug, you should think about 6 key feature you should know about. First one is class. So this clindamycin is antibiotics. Second, for what I'm going to use this one? It's going to be used against this type of bacteria. Third, how we are going to use it. It's oral or IV, if it has any indication for this one, limitation for absorption, stuff like this. Fourth, indication, when we're going to use it. Fifth, contraindication. And sixth is like when we are going to avoid this one and what is the severe side effect of this medication or severe drug-drug interaction with other medication. So this 6 point of each drug, you should know it for each drug. You should know this one. If you cover this, and if you think now it's easy, but trust me, it's not easy because it's almost like 200 drugs. Like 200 drugs, you should know it. You should know the class, you should know the medication, you should know indication, contraindication, you know the drug-drug interaction. So it's not easy. So how you are going to do this? You are going to do this using abstract picture in your mind and then fitting stuff together. So you are going to cluster the antibiotics according to the classification. You're going to speak about NSAIDs to cluster it like aspirin and then irreversible and this reversible. And then you are going to speak about the adverse effects. So adverse effect of opioids are those. But you should know like this one has the least one and this one has more and this one has more potential to be addictive. So it's it's very hard to get used in your patient because this addiction possibility. So you should wrap your mind in a bigger picture and then fit the pieces together so you can understand it. But like if you are going to go drug by drug to do it, it will be so hard. It will be so hard and this is so unpractical. And I think this is the reason why people get frustrated with studying pharma, because you feel like you are investing a lot of effort, but when you are faced with question, you feel like, oh my goodness, I have no clue. I'm so confused. Okay. So here, our answer here is clindamycin. It's not amoxicillin, it's not metronidazole, it's not streptomycin. And if you are awake, we speak about streptomycin to have a severe side effect. If you can catch it, we just said it like a few minutes ago. I hope you can catch it here. Okay? Next question from management. A patient presented to your clinic for endodontic treatment of his upper right first permanent molar. So he's here about like this upper six. His skin was pale, cold, and sweaty. So before you say anything to him, before you do anything to him, you can see some alarming signs because this is not usual. The patient's skin pale and cold and sweaty. During the procedure, he started having muscular contraction and then lost consciousness. What could be the cause for such a sudden incident? And this question, I know, this question will drive some of you crazy. And this is weird concept, so please pay attention and be open to listen. So this patient has a sign and symptoms which push you towards something. I know when you read the question, you think about one condition, but you go back to question, no, he's not diabetic. It cannot be hypoglycemia. And then you go to read, no, it cannot be hypoglycemia. So let's read other option, myocardial infarction, stroke, epilepsy, vasovagal syncope. So I would like you here to trust your knowledge. Do not answer by exclusion all the time. You should trust your knowledge. You have a question giving you clinical signs and symptoms of hypoglycemia. But this patient is not diabetic, and this is not common. I cannot say this is common for patient which is not diabetic to have hypoglycemia, but this happens. And I will show you now from reference and other sources that this can happen for some patient without having diabetic. Maybe they are diabetic, but they are not diagnosed. So trust your knowledge, not the feeling, no, this cannot be happening, because even the other option make no sense at all. Myocardial infarction is sudden pain in the chest. A stroke, like sudden, the patient have blurred vision, have some aurora, stuff like this. Epilepsy is convulsion. Vasovagal attack, a vasovagal syncope, and you might think about this one, vasovagal syncope, and you are like, I think you might think about vasovagal syncope to be an answer here because like he lost his consciousness. But for the vasovagal syncope, let's discuss about syncope. Syncope is like, to put it like in a very simple terms. Think about your body in a crisis, so your body is doing a restart. Like think about this. Like when your computer is stuck, what you do for your computer, you just hit a restart. This is what exactly happens for your body when you go to syncope. Your body is enduring stress that he cannot tolerate. So the vagus nerve overcome everything and go to restart. It restarted everything inside your body, so everything will go down, 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 down till you go to hypo, to be unconscious, and then you wake up and everything will be fine. Because your body think this is the way like he can evade the stress. Because you are stressed, you are afraid, you are under a lot of stress, so your body cannot tolerate being under this stress. So he like lost consciousness, feeling like hoping that like when he come back to be conscious again, you are in a good position. So here you will be stuck between syncope and hypoglycemia, and you will say hypoglycemia. No, because this patient is not diabetic. But when you read about, let's read here about the low blood sugar. So low blood sugar happens when the an adult is below 70 milligram per deciliter. It can happen with diabetic or without diabetic. With diabetic, too much insulin, too much diabetic medication, or cause without a diabetic, eating less or exercising more than usual, some medication, alcohol, underlying condition, or reactive. Reactive, and this is the condition we have here. So our patient came to the clinic with hypoglycemia inside his body, and he was going through stress, so he cannot endure this stress. So he leading to be hypoglycemic and lead to all this. So and then you might think, okay, this is leading more to syncope, correct? But like syncope, as we said, it should be a lot of stress. It should be like, let me give you scenarios when you think about syncope in the questions, because this is like this debate will stay with you till you finish your career, not like finish AFK exam. Because when you go ACG, you will have this conflict and you will see a lot of conflict about it. And from the medical point of view, they don't care. It's hypoglycemia or syncope. It's almost the same medication, the same treatment for them. But for AFK, for ACG, you should differentiate between them. So when you read a question giving you a scenario, patient once he saw the needle, immediately after giving freezing, while doing extraction, this scenario of stress, so you more likely think about syncope. But when you see the same condition, but there is no stress, he's doing RCT, so there is no stress here. But this patient was hypoglycemic, either he's diabetic or not diabetic, as you can see in this reference, and then you can see. And symptoms, your patient will feel hunger, fatigue, shaking, sweating, pale skin, headache, and dizziness, and may lead to confusion, slurred speech, blurred vision, fainting, seizure, coma. So it goes from up till down. And if you cut this one, you put it inside a syncope, it will most likely fit everything. So what you are going to do, you are going to do 15-15 rule. Like you test blood glucose when you suspect you. So if your patient comes to your office, he's not diabetic, you suspect he has a problem. So because he has cold skin, but he didn't deal with it. So you give him something, you measure it. So you found his blood level sugar is low. You give him something to eat. You wait 15 minutes and you measure it again. If it's more than 70, good. You can go for it. If it's less than 70, so you can just, if it's not emergency, you can just rebook your patient again. And so let me give you here another visual about it. Symptoms caused by hypoglycemia, headache, anxiety, tachycardia, confusion, vertigo, diaphoresis. Diaphoresis meaning like sweating with cold face, shaky, increased appetite, blurred vision, weakness, fatigue, lipostrophy, and hypersensitivity. All this, like this is last two is like extreme and in very extreme condition, but like what I would like you to know, at least a 6 in the left side, headache and anxiety, tachycardia, confusion, vertigo, and diaphoresis. And diaphoresis, this is like type of sophisticated word you would see in the exam, and you feel like what this one? This one meaning like cold sweat. Your patient is like you can see him like he's cold and he's still sweaty. So this is indication this patient has a problem with his blood sugar level, regardless he's diabetic or not diabetic. Okay, I hope I know this concept like will drive some of you crazy. I know you might argue a lot about it, but like I'm giving it to you, and then we can discuss together. If you feel like you are not super satisfied with my explanation, we can discuss together. No problem with that. Okay, and anyway, we can exclude the other myocardial infarction, chest pain, a stroke. We see sudden severe headache and aurora, stuff like this, epilepsy, convulsion, and then vasovagal syncope need a sudden stimuli and stressful procedure. Here, patient is endodontic treatment, and you start it and during the procedure. Like nothing during the endodontic treatment procedure would be stressful for patient. But if we like flip the question and we're saying immediately after giving needle, once the patient saw the forceps, so you might think about this syncope. Okay, I hope this is clear because this question is crazy. Okay, next question again from management. A 59 years old male patient present for a dental checkup. The patient medical history is non-significant, and this is extremely important point. During a geographic examination, the patient suddenly reports feeling chest pain. Which of the following is the most appropriate management? So here we have two pieces of information that are extremely important. First one, medical history, non-significant. So this patient has nothing. He report you nothing. And during radiographic examination, what do you think about X-ray taking? Is it stressful? No, nothing. It's a piece of cake. Nothing at all. But your patient report chest pain. So this is so serious. So what you are going to do for him? And this pattern of question you might see frequently in the exam, because he giving you the condition and then asking you about the management. He didn't ask you the diagnosis, but like if you don't know the diagnosis, you cannot decipher the information. So you should reach the diagnosis so you can pick the answer. You do not read the option because like you read the option and say, okay, this one for this condition. So let's read the option. Administration of nitroglycerin and dismissal of the patient when his symptoms subside. So this patient, what do you think about this patient? So if your patient has stable angina, so you do this one. Administration of salbutamol, this is for asthmatic patient. Administration of nitroglycerin, aspirin, activation of emergency medical services. So we here speak about myocardial infarction. Administration of aspirin and referral of patient to the physician. We never do this. Only aspirin? No, we don't do this. So let's read the reference and then we can discuss it. Okay? So management of a chest pain. So before we go deep into this one, there is a very important point you should know before you proceed to anything. First point, recognize problem. Chest pain, no history of angina. So if you have no history of angina, so you are going to think about it in totally different way. Okay, so let's know why. Because if history of angina, so you think about it, it's angina, stable, non-stable, or you might think it's MI. How are you gonna think it's MI? We're gonna discuss this later, but let's speak about the main problem here. Patient with chest pain and no history. So if you have no history of angina, so what you are going to do, activate, and this one, you presume it's acute MI. You are not going to say, no, this might be angina, let's give him nitroglycerin and hope for good. And then later when you think, no, it means MI, and you call him ambulance, while ambulance is here, the patient is dead. So if your patient has no history, immediately you think about MI, you activate emergency medical service, and you start give him medication. And here come the pain. Honestly, this is so painful and so unfair. But listen carefully, especially if we're going to exam soon. You are going to start with oxygen first, and then you are going to give him nitroglycerin, 1 dose, if the systolic is more than 90. And then you are going to give him aspirin, chewable, and then you are going to manage the pain by nitrous oxide or by morphine. So here comes the pain and the question you are going to ask me. Why we start with oxygen? Why not nitroglycerin? Why not aspirin? What not morphine? Because this patient is like in severe pain. And I wish I can give you like a very good answer, but like if you read more in this same textbook, I didn't bring it, but like if you read more about it, they consider oxygen to be the safest way because like read nitroglycerin if systolic, chewable aspirin if it's aspirin might your patient might have some allergy to aspirin, so how you are going to deal with him. So this is the one point there is no contraindication for oxygen. And moreover, and this point, the other point make more sense other than the first point. Your patient has chest pain, and this chest pain most commonly is angina. So angina, we know like less blood flow, less oxygen to your heart because your heart has no sufficient oxygen supply, so you feel this pain. So the main idea here to give your patient more oxygen so he can breathe independently, and then your patient can restore the supply to his heart so he can do this. And this reflect dramatically with nitroglycerin, because when you give your patient nitroglycerin, what is going to happen? He will go to severe vasodilation. So when you have vasodilation, there's a blood supply going back to the heart will be less. So meaning less stress over your heart. And then you're giving him aspirin, hopefully that you will prevent any clotting that might happen. And then you manage pain with morphine. So now I explained to you why we're giving the medication to the patient and which level of medication, which level the medication is targeting to manage the condition. So I think now you can understand it, because when once it was explained to me, it was like you just give him oxygen first, because the other medication like has some condition that contraindicated. So like he didn't ask me to measure his blood pressure before giving him nitroglycerin. So the condition here, or the idea of managing the emergency for our patient is to treat whatever we think is the main cause. So the main cause, our patient has a problem with his blood supply to his heart. That's why he has severe chest pain. So I'm going to giving him oxygen to give him more like relief for his oxygenation of the lung and heart and everything. And then we're going to give him nitroglycerin, and you go with the other medication. I know some people think I'm so silly to spend a lot of time explaining this one, but trust me, if you go to exam, you might see some question about this concept, okay? Okay. So here what we're going to do for our patient, we are going to give him nitroglycerin as pre-activation of emergency medical services. So I hope you understand the concept and you understand why we're giving this medication. And this is the beauty of management. That's why I love management more than pharma, because management is like the applied part of pharma. It's like the definition of physics and applied physics. Like physics, you study like abstract concept. You study abstract concept like this rule, stuff like this, and what happens here, what happens there. And then when you go to real life, you do applied physics. You feel like, oh, this is interesting. So that's why we have been wasting or investing a lot of time studying pharma and studying medication. How does it work? Why we are going to use this one? Why are going to use this one? Okay. I hope that was enough for you. Last question from management. A patient arriving to your clinic for a regular recall appointment. So your patient has no pain, and this is so apparent from the first line. At the front desk screening, the patient temperature was 38.3, which is high because like the normal patient, like between 37.5, 37.7. And he complains of coughing and fatigue. Which of the following is recommended management for this patient? And this question is from the COVID era, the glory COVID era that ruined the whole world. So what we're going to do for this patient? So this question is speaking about, like in short, in two sentences, COVID patient in a recall with no pain. So what you are going to do with him? So your patient is coming with no pain. He's just coming for a recall appointment, take X-ray, and speak with you and check whatever he has in his teeth and the condition. So let me give you the option. Use strict infection control measures and complete the appointment. Use strict infection control measures and avoid aerosol generating procedure. Reschedule the appointment till the patient health is normal and the infection that he has is resolved. Use normal infection control measure and complete the appointment. You remember like maybe 2 or 3 newsletter we speak about, I cannot, the stupid option of leaving endodontic tooth open, like I'm going to open the tooth and let the patient go home. And I told you never, never, never pick this option. Same here. Use a strict infection control measure. This is like so ridiculous. We use strict infection control measures with everyone. If you are going to say, no, I will like double my infection control measure for this patient, so you violated everything. You violated everything for your patient, for your staff, for yourself, because you like, this mean like you cut loose with infection control with other patient? No. So this option, boom, you will never pick it. So for the COVID era, I was looking for like a good reference to give it to you. So I came upon about this website, MDBI. And this website is like is a publisher of fully peer-reviewed open access journal with a focus on robust and rapid editorial processes. So like to cut it in English and make it short for you, this like peer review meaning like during the COVID, they came up with protocol guideline to follow, stuff like this. So this beautiful website they aim to collect the guidelines and test it. Like it go like a systematic review. I cannot say systematic review exactly, but they go to modify and look in this one, look at this one, and say, okay, we are going to follow this one. So this website is amazing. I have a lot of reference from this website, and I will leave you the link for the article from this one. So let's speak about COVID patients. So if COVID patient come to you, so what you are going to do? You are going to ask yourself very important question. Does your patient have a swelling? If he has a swelling, does the swelling restrict to swallowing or extend to the eye? Yes, immediately you interfere with him and you try to treat him. There is no way you can say, okay, just go home because you have COVID. No, you should treat him because this is so unfair. He might lead to complete airway obstruction and he will be dead. So you should treat him regardless of anything, and then we can discuss later the measurement we are going to use with him. And to cut it short for you, like think about him like an active TB patient. If you have active TB patient, what you are going to do with him, how you are going to treat him, and he's in severe pain, how you are going to treat him, the same you are going to apply for this patient is the same you are going to apply for the COVID patient. And then you ask yourself three other questions. Your patient is in pain, or your patient suffered trauma, or your patient has a bleeding. So if you ask yourself these three questions, if it's no, so okay, we can give him some medication and speak with him and let him go home. But if yes, if your patient has pain, or if your patient he has no swelling but he has pain or suffer trauma or suffer bleeding, so you do self advice to him. You give him some medication. You check the previous medication. Maybe he has weak medication, so you give him strong medication. Maybe he used like over the counter Tylenol. Maybe you can give him T3 if he's contraindicated for some strong NSAIDs. But if your patient has a trauma or post-extraction bleeding, how you are going to deal with him? And this leads to the last part of our algorithm here. And then let's cut this one. If bleeding uncontrolled, you are going to deal with him as emergency. You should treat him like regardless he has pain, he has no pain, he has swelling, he has anything. Like he did extraction and he come to you like second day and he has bleeding. It is uncontrolled. You ask him to buy it on a gauze, you ask him to buy it on a tea bag. It's not working. So you should interfere to deal with him. If the pain is severe or uncontrollable or spreading recurrent continuous infection or a permanent tooth or severe trauma, you need to deal with him also. But if your patient has pain which is mild to moderate and swelling is mild to moderate or minor dental trauma, exposed dental or other primary tooth, you postpone everything, you don't treat him because the benefit the patient is going to gain from you treating him is way less than the risk you are going to expose yourself and expose everyone in the office and expose the next patient for the next maybe like 24 hours. They did like this aerosol test. I did work during the COVID and it was like nightmare. Just going to the clinic, it was a nightmare. So hopefully now we don't follow this strict like protocol about this one. But like anyway, I don't want to like blow your mind about this one. But the bottom line here, if your patient has mild pain and no swelling that obstructing his airway, no severe bleeding, you can control him. So you can just let him go home and come back to you and then you can treat him. So if you want to read more about this one, I put the link for the article here, and this website is very good. It's amazing website. I would recommend you just at your spare time. This is weird to be said, but like yeah, this is how it should be. In your spare time, just go to your website and read some articles. Okay. So here, use a strict. We said we'll never pick this option, so we're going to reschedule and until the infection and then resolve. Like infection is not the dental infection. I mean like this throat and the coughing he has. Okay. So I hope this newsletter was beneficial. Trust me, the question I'm going to give for the newsletter from now till the FIP exam are extremely important. I wish you can follow it. I wish you can read the question because like this is the feedback I received even from people didn't take the mock package. One of the lady like she gave me a good vibes honestly. She sent me like the question you give in the free mock sample and the newsletter. Some of them came in the exam, so that was like really amazing for me because I know that. So please, the concept is not like wording of question. Like we are bigger than that. I'm not giving you the wording of question. I'm giving you the concept. I'm giving you the knowledge and information you need to tackle other question. And this is the important part. I'm not going to give you question. No, this is so this is fishy. Okay. Thank you very much and see you next Sunday.